Good afternoon and welcome to this webinar. And we'll be asking the question this afternoon, is risk assessment for suicide finished? My name is Niall Boyce. I am the editor-in-chief of The Lancet Psychiatry. Now, in all of mental health, talking about suicide, talking about suicidality is one of the hardest things that we do as professionals, whether we're psychiatrists, whether we're mental health nurses, whether we're other professionals involved in the system. And I remember many years ago when I was a trainee, talking to a senior colleague who said that it was strange to him, still strange to him, that one of the most important, one of the most difficult and high stakes things which we did as professionals tended to happen in accident and emergency departments in the small hours of the morning, tended to be done by quite junior members of the team, and this tended to be done in a very unsupported way. Now, this was many years ago, this was maybe more years ago than I care to remember, but it's still the case that risk assessment, suicide risk assessment is something about which we know very little, despite the fact that it is such a central and important part of mental health service delivery. And it was really in an attempt to get a clearer picture as to what's actually done on the ground, what assessment instruments are used, and how everyone feels about it, how clinicians feel about it, how families feel about it, and most importantly, of course, how people who use services feel about it. It was in an attempt to do this that Jane Graney and colleagues carried out a research project, which we have just published in The Lancet Psychiatry. Now, today, what we're going to be doing is hearing from one of the authors on that paper, Professor Nav Kapoor of the University of Manchester, but we'll also be hearing from Bibi, who is an individual with lived experience who contributed a comment on that paper. We're going to discuss this paper among ourselves and also take questions from you. I have a few points of housekeeping before handing over to Nav. The first thing is, if you have a question, please pop it in the Q&A box. Other things can go in the chat box, but only questions should go in the Q&A box, please. Secondly, I should stress that Bibi is here under conditions of anonymity. It's possible you might know her, but it would really be very, very much appreciated if you could help to preserve this anonymity and to respect that. Thirdly, if you're going to get the best experience from this chat, it's probably best if you set your setting, your Zoom setting, to gallery view. That's all I have to say for now. We're probably not going to get any easy answers today. This is going to be a complex and very sensitive discussion, but it's often this kind of discussion which I think provides us with the best route forward in terms of really changing care so that we provide the best possible care for people at moments of intense crisis. And having said that, I'd like to now hand over to Nav, who will talk about his research. Thank you, Nav.
Thank you very much, Niall. Good afternoon, everyone. I can see there's 272 of you listening in today and counting. Thanks for coming. Thanks to Niall for hosting this web chat, and thanks in particular to Bibi for her really kind of insightful comments on our paper. So what I'm going to do briefly is just tell you what we did and what we found. But first of all, a little bit about why we did it. So I know some of you who are watching will work in mental health, and everyone that works in mental health is obsessed with risk assessment. There's this idea that we can predict what might happen, but unfortunately, we're really not very good at predicting outcomes. You know, we can't really predict who goes on to hurt themselves and who doesn't, and we can't go on to predict those people who, you know, very tragically go on to take their own lives. So this notion of risk assessment, in some sense, is a flawed one. But the idea these risk tools and risk scales can help us persists, and despite guidance, despite research, they continue to be used. So we wanted really to get a handle on, you know, how they were being used, what was the kind of real life experience of people using risk assessment tools. So we did a national study. And what we did was and I say we, I mean mostly Jane Graney, the lead author, ably assisted by Isabel Hunt and many of our other wonderful staff. What we did was we wrote to every mental health service in the United Kingdom, and we said, look, give us a copy of the risk assessment tool that you use. And then we looked at them and analysed those. We had a web survey where we invited comments and views from patients, their carers and clinicians. And then we did a more focused interview study with just a sample of clinicians to really get to grips with how they were using risk assessment tools. So what did we find? Well, the first thing we found was that, we surveyed 85 mental health services and we said, give us your risk assessment tools. And we got back not 85 different risk assessment tools, but 156 different risk assessment tools. So that tells you something straight away. The tools varied. Some of them were a page, some of them were 20 pages. Contrary to national guidance and what we think is best practice, 80 to 90% of them attempted to categorize people into risk categories based on kind of checklists. So using a checklist and using a kind of prediction paradigm. And they weren't very kind of collaborative. So very few of the risk assessment tools invited kind of a collaboration with families, suggested that general practitioners to be involved. So that was what we found for the content. The views, I think we'll talk a bit more about later, but the headline there is for service users, very few were offered kind of collaborative assessments. For some service users, the assessment was experienced as rather impersonal. One quote that I remember was, it was like a government survey having a risk assessment, undergoing a risk assessment. Other people saying it didn't really capture the complexity, so one question wasn't enough. And somehow this formulaic approach to assessment detracted from what should have been a collaborative therapeutic encounter. From carers, we got the same thing about a kind of lack of involvement, quite a strong message about a lack of involvement. And from clinicians, we got a bit of a mixed message. So some people liked these risk assessment forms. They liked the framework. They thought it was helpful as part of the assessment to help people as part of the assessment. But other clinicians talked about long forms that took ages to fill in, that might not be read, that might provide a false sense of security. One of the other really striking things that, again, we might want to pick up during the discussion is the role of risk assessment as communication. So the professionals were telling us sometimes, well, the risk assessment is quite helpful because it acts as a means of communicating between services. But on the other hand, some of the service users were saying, well, actually, it was a tool that actually diminished the quality of communication. If someone was filling out a checklist, they weren't communicating in the way that service users would like. So that's just, Niall, a bit of a kind of heads up of some of the findings and what we found.
Thank you very much, Nav. And just a reminder, because I'm just seeing some questions beginning to come through on the chat, if you could put questions in the Q&A box, that would be great. What I'm going to do now is hand over to Bibi, who is an individual with lived experience who wrote a very, very interesting comment on your work, Nav. And Bibi is going to give some feedback on the research which you did and some of the questions which this raised for her. Thank you, Bibi.
Thank you. So I don't usually do this kind of thing, so I might stumble a bit, so please bear with me. When I first saw this paper, my immediate reaction was kind of, don't we already know all about this? And I guess for like so many other things, sometimes you just need systematic investigation before anything can really be done to change things. So I'm glad the study has shown really clearly the full extent of the use of inaccurate risk prediction tools in services. I think that the thing that struck me the most about the study and the results was that the feedback from clinicians and service users and carers didn't really relate to the tools so much as things like the therapeutic relationship or better communication or being involved, as Nav has just said, and also a better, more personalised understanding of risk. And that tools were seen to kind of get in the way of those things, at least by some clinicians especially, which makes sense to me because sometimes it can feel like the tools have kind of actually been invented to kind of paper over those kinds of issues. And in terms, I guess, of the fact that they were highlighting suicides that happen after a contact where a risk assessment has deemed somebody to be low risk. I think that also kind of made a lot of sense to me, because any contact that you have is kind of, it's a sum of all the contacts you've had before. So how can you open up about something that will keep you safe, or that you're at high risk, if you keep getting told that you can only get therapy if your risk is lower, or if you've only ever had poor responses, or if your risk has been dismissed in the past? What would be the point of telling somebody that? And because actually every person I know that has actually taken their own life, or who has come close to it, has experienced some kind of abuse or neglect from services. And I think that comes from a kind of fundamental misunderstanding of suicide, of risk and trauma, and the view that sometimes our actions are wasting precious time and resources rather than being symptoms of massive amounts of distress. And I think that sometimes that's dismissed in a way as unacceptable, but a rare anomaly, so not really significant when we're analysing data for suicide prevention. But I don't think suicide is so common that these kinds of experience, even if they are relatively rare, couldn't play a significant role statistically, as well as on that kind of individual level. So I really wanted to hear more from the clinician interviews, specifically about that kind of difficulty and misunderstandings, and from their perspective, why they think somebody who was high risk might be seen to be at low risk. And I especially would have wanted to hear more from service users and carers about that, because that is, I guess, basically half or 2/3 maybe of the information from that interaction. And I guess, and these kinds of misunderstandings and the kinds of issues that have been brought up, I guess, like there's an example of that kind of thing which can lead to inaccuracy, which is that sometimes, because of the subjective nature of that, for example, if your trigger for your distress is judged to be understandable or not, can play a big part. I was told to just go home when I was asking desperately for help once, because the trigger had been something that could be considered to be extremely trivial, and I'm not going to tell you what it is because that's embarrassing. But another time, the same doctor was so concerned about my risk because I'd suffered a bereavement, and he refused to prescribe me more than a week's supply of my medication, despite the fact that I wasn't remotely suicidal, and that actually I was struggling to get to a chemist on a weekly basis. So they can be inaccurate because we aren't understood, but they can be inaccurate because you can't measure emotions without affecting them. And I don't think that's acknowledged enough, or at least the effect is underestimated. Because you can probably imagine a tool being used, causing an interaction to feel impersonal and maybe awful. But there are more aspects to that for some people, and I kind of wanted to get that across. But it may be slightly triggering, and so if somebody wants to mute me for the next couple of seconds, then please do. So basically, if you arrive at A&E in need of immediate medical and emotional attention, somebody asking you a list of irrelevant questions is more than just impersonal, because like in that state, it can also transport you back somewhere else. It can feel like you're being inspected for injuries which are being measured and described and noted by a police medical examiner, or it can feel like an abuser who will only tolerate you speaking if it's what they need to hear from you. Or the questions might be the exact same ones in the exact same order you heard before you were sectioned and restrained. And those things are going to have a massive impact on how you feel and your risk. So for me, I guess some of this boils down to the fact that if you can't measure someone's risk without having an effect on it, actually that's okay. You don't need to be accurate, and you do want to change their risk. You want to reduce it. And so these interactions should really be more about what you need to stay safe, and whatever it is, we should be able to offer it to people. But I think maybe the reason services do focus on risk is because they can't actually offer the things that might help keep us safe, because the things that we need might not always come from changing our thinking or from more coping skills. it might need services to be more flexible, and they might need more resources to offer extra support, for example, for people to access therapy, even if they're high risk, or advocacy, or longer term contact, but maybe more infrequent contacts. It may seem expensive, but I don't think that we can afford not to do that. But in the meantime, and if those things don't come to pass in the near future, I think really the most basic thing would be to just actually acknowledge that and say that it's not okay, and just try your best to find whatever support that you can, because you can't fix something. Even if you can't fix something, you can still be kind, and you can still be willing to see what's actually wrong and not kind of pretend that that's not the case. And I think that's kind of where I am going to leave it.
Thank you very much, Bibi. Now, you know, your comments in the Lancet Psychiatry and your remarks just now, I find quite concerning, because it seems to me that risk assessment in any context is in the context of a clinical encounter between a mental health professional and an individual in distress, and that this should be a point of supportive connection. But from what you've said, it sounds as if this is more a cross-purposes conversation, in which, for example, it might be that the person has come to A&E or has come to the clinic expressing distress and wanting support. And the psychiatrist might well think that what they're doing is figuring out a way to offer that support, but it's experienced by the individual in distress as a process of gatekeeping, as a process of the clinician effectively saying, well, let's just make sure you're not too distressed or not distressed enough. You know, we want to get, you know, and that surely is inimical to the very point. And I'd be very interested in Nav's response to that.
I think that was great, Bibi. Thank you so much. I think you're absolutely right, and it's something about the, you know, where quite often when you have a discourse around risk assessment, people are obsessed with the what, you know, what are the questions that are being asked, you know, what score might people get, etc. And I think Bibi's comments are a reminder that actually for the service users themselves, it's quite often about the how you're asking. It's, you know, you being empathic. She mentioned being kind. Those are the things that are often, well, undoubtedly more important to the individual who's in distress. So, I mean, I think that's most clinicians would fully accept that, you know, we need to assess and you know, offer people help with compassion and kindness. But you're right. I think that's one of the real dangers. Often people will say to me, well, you know, the risk assessment isn't doing any harm, is it, Nav? At least we're getting some kind of you know, ballpark indication. But actually, Bibi's shown us that risk assessment, when it's carried out in this unthinking, impersonal way, can be harmful, actually.
Yeah, and actually, I mean, even when it is more interactive, there's so many possibilities for misunderstanding, and it's so difficult to communicate your own risk without all these other factors in your head about how people might respond to that I'm not sure you're ever going to get a kind of accurate reading, if you like, and that, yeah, so in the end, we just need to help to keep people safe rather than try and work out what would happen, what their kind of risk level is.
Thanks, Bibi, and thanks, Nav. Now, I've got a lot of questions coming through in the Q&A, so I'm going to get to as many of these as I can. Now, the first question is from an anonymous attendee who says, it seems that many trusts are using something called positive risk-taking, and this person would like to know the panel's view about this. Bibi, do you think you can start with that one?
I can. I think certainly what I've heard of people's experience of this is maybe very different to how it has been designed to be, or the thinking behind how it was initially came about. I think sometimes I can kind of understand what the point is. It's to be not overly restrictive with people, to let them still access things whilst at risk. But I guess the problem is in this kind of culture where we are focused so much on how little resource we have and how difficult it is to manage those resources. I think quite often it's used as a way to say, well, you know, here's an excuse for leaving people at more risk. So yeah, I think.
Yeah.
Nav, what do you think of that?
Yeah, I mean, I think so. Some of the people who are listening in might not know what therapeutic risk-taking or positive risk-taking is. So it's coming from this idea of recovery. So it's coming from this idea that if we have a psychological health problem, actually, if the people providing care tolerate a little bit of risk, so for example, you know, encourage us to manage at home rather than under supervised care, that fosters a sense of autonomy. We kind of, if you like, get through that adverse period, and it increases our capacity and our autonomy, and you know, in the long term is kind of better. It's the part of the recovery agenda. The research evidence behind it is not huge. There's not been very many research studies looking at the approach, but I think what Bibi says is very important. It's a bit like, you know, risk assessment and this study, how it's used in practice, therapeutic risk taking and how it's used in practice. You know, there is a danger, I think, that sometimes it could be used as an excuse for non-intervention or non-treatment. People saying, oh, well, you know, we need to take a degree of therapeutic risk here, and it's used as an excuse to not intervene. So I think that's one of the things we need to be mindful of. And the other thing I would say with approaches like therapeutic risk taking and similar things is we need more research to really figure out what bits are helpful and unhelpful.
It strikes me that very early on, we've got to one of the most important points here, which is that whatever we're talking about, whether we're talking about risk assessment tools or whether we're talking about positive risk taking, these are theoretical concepts, but they don't take place in a vacuum. They happen in the context of mental health services, which are underfunded, which are under-resourced, which are often quite risk averse, in which a blame culture operates. You know, how effective can any of this be if we don't address these underlying deep issues of mental health services? Bibi, what do you think?
Well, I think I probably agree with that. So I think, so one of the things that I really think is that maybe a lot of people who work in these services are so frustrated by the fact that we won't get better. We've got so many coping skills thrown at us, and we have had so many answers suggested. But I think really sometimes it's because the thing that we need that would kind of break us out of this cycle, that would instill hope in us, is a thing that can't be offered with the kind of resources that we have. Which kind of just sets us up for this cycle of just assessing people's risk and then not being able to fully help with that. Because I think sometimes we're underestimated in how much we have put into practice our coping skills, how long it takes us before we decide to ask for help. We're not, on the whole, as far as I know, I don't know anyone who, you know, asks for help at the drop of a hat. If anything, we wait longer than we probably should. So yeah.
Yeah, I mean, Nav, what do you make of that? Because, you know, my experience of medicine is that people don't tend to come to doctors until they're already in a bit of trouble, and that seems to be even more so in the case with mental health services.
I think it does, and I think you're touching upon something very, very profound, which is the organisational reasons or the organisational functions of risk assessment. So sometimes, you know, one memorable quote is risk assessment is actually a ritual. It's a ritual for decreasing institutional anxiety. So understanding, you know, why in mental health there's this culture of risk assessment, I think is a very profound one. And partly, I think it's what you're hinting at, which is it's to protect kind of organisations rather than as what it should be about, which is providing the best possible care to the service user or patient in front of you. So addressing some of those very interesting cultural reasons for risk assessment, I think it's kind of fascinating.
Thanks. Now, I have two quick questions for you, Nav, from the Q&A. The first is, do we know what training clinicians got to complete the tools? And the second is, there were 150 different risk assessment formats from how many trusts? So those
Yeah.
are just two sort of technical
Yeah,
ones.
so that 150 were from about 85 trusts. So, you know, but I mean, the point is they were all different, and actually not all of them were different, but a third of them were actually risk tools that were locally derived. So these were risk tools that people had locally kind of derived. So I think, yeah, that's a really important point. Sorry, Noel, just remind me of the first point. Sorry, muted.
The first point was the training that people received.
Yeah, so the training was really interesting. So that came up with clinicians, it came up with patients, and it came up with service users. The importance of training, and the importance not just of the initial training, but of supervision. In fact, the training was very variable. Only a minority of people had been trained in the use of the risk assessment tools. But I think it's wider than training just in the use of the tools. It's a more general training issue about how, you know, we ask people to assess and manage people who have either hurt themselves or expressing, you know, suicidal thoughts.
Thanks, Nev. Now we've got a question, just a reminder, of course, risk assessment isn't just a matter for health services. We've got a question from Andy Hunt, who's a police officer, and has said, as a police officer, we all cling to risk assessment for the false security it seems to provide. And that from your study, what are your recommendations around assessing clusters of high risk behaviors that seem to be predictive? Do you have a model of assessment or higher risk triggers you can recommend? And it sounds as if we're maybe slightly talking around Andy's point here, which is that that'll be different for individuals. And so, Bibi, you mentioned something earlier which I wanted to follow up on, which was that you were concerned that something which might be seen by others as trivial was in fact to you very important in risk assessment. And that by just talking about things which are risky or not risky, traumatic or not traumatic, we really risk washing out the importance of these individual factors. I wonder if you could say a bit more about that.
Yeah, I think the example that I gave is, I think, an example of how things are so personal. And so even if there are kind of population patterns and what may predict risk, that in the end, the person in front of you may not at all conform to what you think is the case. But this is one of those things that isn't necessarily a risk factor. That's known. It's just, I think, people's own judgments and I guess what they relate to. And I think sometimes it's hard to let that go and really listen to the person in front of you. And I think sometimes it's hard to take notice of distress rather than the cause of that distress, which I think does need to be looked kind of separately at.
Thanks, Nev.
I mean, the idea of, you know, what's the key elements here, which is, you know, partly behind the question, is a really important one. And, you know, if you're not careful, what you get into is just constructing a new risk assessment scale by another name. But, you know, we know some of the things that are important. But actually, I think some of the things that come out from this study are, you know, what are the important principles? So, you know, Bibi's already kind of really wonderfully highlighted the importance of risk assessment being individualized. So, you know, the factors aren't necessarily kind of uniform. People are involved, so families and carers and others are involved, that the clinicians are adequately trained and supervised, people, when they've left an assessment, don't feel kind of unsupported. They've got, you know, an idea of what comes next, an idea of what might keep them safe, and the really important notion that assessment isn't an end in itself. It really leads to us to, well, what are this individual's needs, and what can we, for example, in a clinical setting, do as clinicians to help address those needs? So, in a way, I think these are the kind of principles, but it doesn't really answer Andy's questions about, well, what should be in one, because actually I think in some ways that's too prescriptive.
Thanks. Now we've got an interesting question here from Owens C, who says that raising this issue of poor predictive value and counterproductive nature of suicide risk assessment doesn't seem to gain any traction. And our regulators, i.e. the CQC, do have a role here. They encourage us to produce ever more elaborate and continually updated risk assessments. How cited are the CQC leadership on this work? Now, I kind of get this point, because one of the things which we have to say is that if you do a risk assessment or not, that's a measurable outcome. And one of the ways to ensure quality is to have measurable outcomes. So I can see why there would be pressure from people whose role it is to ensure quality on doing risk assessments. How do we get around this problem now?
It's a really tricky question. I think we have to understand why. The first paper I published on this was in 1998. I'm essentially saying the same things now that I was then. I think the message is getting a lot more traction than it was. It's in the NICE guidelines. It's been in other national guidance. We've done lots of research. And when I go round to clinical services, quite often they kind of get it. But understanding why these things persist, I think, is really important. And we've touched upon some of them. Some of them are this kind of cultural notion that they're better than nothing, that actually they provide us with some reassurance as clinicians. That I think we need to address. The other thing that came out here was there were elements of risk assessment that the clinicians in particular found genuinely helpful. So this idea about communication, this idea of a kind of clinical shorthand, this idea of a prompt to help make sure they didn't kind of forget important aspects of the needs to consider. But so there are those things that some clinicians are getting something out of this. So, we need to understand what that is and provide it in another way. But then there are some very troubling aspects to why risk assessment persists, because, BBC kind of hinted at this. Sometimes it can be used as a justification to, not ration treatment, but if someone isn't at high risk, they're not going to get admitted to a mental health inpatient bed, and also conversely as well. So I think we need to understand some of the reasons, and then we need to chip away at some of the cultural things about how we move on from this. But it's really important. It's a very fine distinction between the risk assessment and the scores and the categorizing people into levels of risk with a view to predicting what might happen. And I think we're kind of agreeing that notion of risk assessment as prediction is a bad one. That's one thing. But then, if you like, there's a wider kind of assessment function that, of course, we're saying, we have to maintain, we have to do the best possible job we can. So it's that predictive element, it's that mechanistic or depersonalizing assessment. I think that's the problem. But the other stuff, of course, we've got to do. That's a core part of clinical practice.
Well, that leads us very nicely on to Callie Hayes' question, which is directed towards Bibi, and that is, what qualities in clinicians who have assessed your risk have been useful for you in helping you to feel safe? Bibi.
I think usually the best ways that I've ever discussed risk has been in situations where you wouldn't know it was a risk assessment. So it was part of maybe psychology. So I'm going to say that mainly it's psychologists who've done this best. And so maybe that's because they spend so much more time with us and they get to know us. And so it hasn't, you wouldn't know it was a risk assessment for a start. It would be a conversation about what we can do to keep me safe, what are the things that we can put in place, and can we change that risk? Are there ways of completely changing it and not just having to manage it? And also how the therapy would maybe impact on that. So I think it's very in depth, I think, which is maybe another barrier for why it doesn't happen so well, because that takes time and it takes a lot of effort, I think. And I guess if you're rushed for time or you have to see a lot of patients, those are things that are quite hard to find. But yeah, I think those are the qualities.
So I notice you're nodding in recognition or agreement now.
I can't really kind of add to that. I think it's just spot on. The idea, I think, of, you've articulated it really well, Bibi. The idea of risk assessment as a kind of conversation. I mean, I think that's just spot on. That those are skilled clinicians, using their interpersonal skills, fostering rapport, being kind, being compassionate, but actually also getting the information they need in order to provide the best possible care. So that's the assessment as a conversation. I like that very much.
Thanks. And now we have a question from the perspective of ambulance services. So this is from Darren Earley, who asks, would advice to ambulance services responding to people with self-harm, suicidal thoughts or concern for welfare be to focus on the therapeutic and holistic encounter rather than the hierarchical and dispositional outcome? And this, of course, includes a process of shared decision-making. Bibi, what's your view on this?
I mean, I would answer that. I would answer yes to almost anybody asking that question, I think. And yeah, so I think I'm just going to say yes. I think there's no way that you can, there's no other way of doing it really in my mind. Like I can't envisage another way of doing it. Sorry, that's all I've got to say.
Yeah. I think of course it's got to be holistic of, all the things we've talked about, but obviously you're taking into account the individual circumstances as well. So, if it's an ambulance person attending, you're taking into account, the clinical circumstances, what's happened. You're taking into account kind of social supports, the immediate medical needs. Of course, you're taking those things into account. It's an individualized thing, but you're providing, you're doing that information gathering, you're doing that kind of assessment in this holistic, compassionate way.
Thanks. And there's a very interesting question from another anonymous attendee here, which is about, I think, another hugely controversial issue in psychiatry, which is this issue of personality disorder. And this question is, there are many patients within services who have a diagnosis of personality disorder. Says the harm of this diagnosis has been well documented for many decades. People with this diagnosis have a high risk of suicide, but are often turned away from help when suicidal and told to take responsibility. How can things change? Bibi, what do you think of that?
Yeah, so I think that is absolutely true. I think it's difficult because obviously the fact that services don't actually want to keep people on forever is one of the kind of probably major driving factors of the difficulties that they have with helping people who are diagnosed with personality disorder. I think sometimes we have to admit that people might need help for a long time. And I think that's something we don't do. And I think sometimes that insecurity drives more and more distress and desperation from people. And I think it is something that, you're kind of working against yourself if you keep telling people to take responsibility, because as I said before, people do take responsibility. They try and cope for as long as they possibly can. And I think sometimes the things that would help are quite practical things, and they're things which aren't available. And so you get into this situation where instead of being really honest and saying, well, obviously, if I could take this off your hands, I would, but I absolutely cannot, like, there's no way I can manage to do that. I think that kind of validation is more important than being like, I don't know, trying not to show how powerless you are or that there's flaws in the service. But yeah, I think it's mainly around this idea that you shouldn't be dependent on services. And I think sometimes people don't have the family or the support networks or whatever else it is that helps people to be able to cope without services input. And yeah, I don't think that's always possible to change.
And this leads on to another question, again from an anonymous attendee, who says, powerful stuff from Bibi. I think also some of her comments hint at the question of who is risk assessment designed to protect. Is it actually protecting the suicidal person, or is it about protecting clinicians from subsequent legal or professional action in the event of a death by suicide? Nav?
I think if the honest answer is in practice, it's asking ourselves why these things persist? So the honest answer is probably a bit of both. And I think, in some ways we need to be a bit upfront about that that's what these things are being used for. I mean, it's quite interesting. Coronial colleagues still, when there's a tragic suicide death in services, they will still ask, well, where was the risk assessment? And, what was the tool used, etc. And so we need to try and get through some of these, I think, cultural misunderstandings, really. I think at the moment, that's right. Partly they're used, partly as a kind of, as I said, a ritual as part of defensive practice. And really we need to get back to the nub of what they're for, which is about helping people. And I think it's just about, in terms of what we do, it's about addressing some of those misconceptions, really.
I mean, this is a point which Chloe Beale makes in the Q&A, saying that although there's all this evidence, including the evidence in the recent paper, these practices are still, as Chloe puts it, utterly ingrained in mental health culture. Why are we still doing this? How do we go about undoing this? Bibi, do you have any thoughts on that? Changing a culture. I know it's a small ask, but
Yes, absolutely. I have a magic formula. So I think maybe we just need to ban them, because I think the very words risk assessment just do not imply a conversation. They just don't conjure up the idea of creating safety. I think we just have to maybe just say, no, you can't do risk assessments anymore. What you can do is plan for safety, make sure your patients are safe, and that if there is kind of legal action, what people should be looking for is a different thing to some kind of risk assessment tool being used. It should be maybe how you conduct them, if they're personalised, if your other patients feel that they feel safe by the way that you do your risk assessment, your safety planning.
well, that's it. It's just so hard to get away from the language and the mentality of it, isn't it?
I think it is. I mean, this idea, one of the things we've tried to do, language is quite important. And, again, I'd like to emphasise, we're still going to need to assess service users. We're still going to need to do, an empathic, holistic assessment. But it's something about, thinking, one of the things we did in the NICE self-harm guidelines was try and subtly change the emphasis. So instead of about predictive risks, the conversation becomes about needs. So what are the needs of this individual? And trying to change the culture that way, really. And also not reducing risk to a score. I think that's been fantastically unhelpful over the years. So trying to, again, get away from that.
So we've got a good question here from Baljit Nal, who says, have any risk assessment tools been designed with service user input, with actual co-production? Who decides which questions are the most important? Nav?
I don't know very many that have been designed with service user input, but there are some, I think, and it's a developing area. I mean, I wonder whether we need to move away from risk assessment tools per se, because, one of the questions is, well, we just need better tools. So the answer here is we just need better tools. And I think co-production is always a great idea, especially when we're thinking about assessment or intervention. But the idea that we're going to get to a better risk assessment tool, I think is a flawed one. And it's a bit like lots of people listening in will have heard about machine learning, artificial intelligence, and how, if you like, if we plug loads of data into these algorithms, that will tell us what to do. And, people like myself will be replaced by algorithms and bots because they'll be able to do a better job than we've been doing. But I don't think that's not the discussion here, that we're not going to be able to incrementally improve risk assessment tools and scores just because, the maths doesn't add up. You're never going to be able to identify those people who tragically have poor outcomes, either hurting themselves or even taking their lives. It isn't a question of incrementally improving these things. So I would get away from that. Of course, though, when we're redesigning services, when we're introducing interventions, co-production, service user involvement is key. I've seen the chat flash up, and people saying, well, we should ask service users, what they think, and that's partly why we did the study. Although except there weren't that many service users in the study, that's what we were trying to get at.
And this is the thing which I come back to again and again as an editor, which is no matter how sophisticated the method is in any area of mental health science, if you're not starting from the right premise, you're never going to get to where you want to go. And this is a point which another question on the Q&A addresses, which is one for Bibi, I think, on the point of service users. What do service users hope the most when they go to crisis care? Now, clearly, Bibi, you can answer for everyone, but perhaps from your personal perspective.
Yeah, no, I can't answer for everyone, but certainly I think a crisis cafe is a place where you can get validation, you can get space, and I think space is a big thing. I think just having space, being able to breathe, not having to stay in that mess that's in your head can just kind of give you a bit of, I'm just going to keep saying space. So clearly that's the most important thing. And I guess time for your nervous system to just kind of relax a little bit, calm down. I think we underestimate the power of environments. I think crisis cafes are probably more suited to soothing a nervous system than most buildings where mental health services are provided. And I think some of that stuff, that kind of physiologically soothing stuff, is seen as a luxury when actually it's kind of a really basic thing that can be done to reduce how overwhelmed you feel. It's something that people do every day. They go to spas, they go to green places. These things are, yeah, they're seen as, I guess, extras for mental health services, but actually that's kind of the biggest part of mental health, is to soothe people. So yeah, I think maybe that's the most important thing about crisis cafes. I don't think we necessarily go there for answers, at least not me.
So the environment, it sounds like this is an important thing. So my experience of A&E departments at 3 o'clock, 4 o'clock in the mornings, they are not very relaxed places at all. They're not a place that you'd feel soothed from anyone's point of view. So Nav, should we be maybe thinking about emergency assessments outside of A&E departments?
I don't know about outside necessarily. There are sometimes quite good reasons why you might want physical health services and mental health services kind of co-located, liaison psychiatrists getting to people kind of quickly. But you're right about the kind of environments that we treat people with mental health issues, mental health problems in. And, I was lucky enough to go to visit Scandinavia last year, visiting some of the facilities, not all of them. There were pleasant places to be, and Bibi raises really valid points about the importance of environment, the importance of green space, and how therapeutic those can be in and of themselves.
Thanks. Now we are running out of time, I'm afraid. I did warn you at the beginning that we weren't going to come up with easy answers. What I didn't anticipate was quite so many questions. If we haven't had time to get around to your question today, I'm very sorry. But I'd just like to finish off by returning to our initial point of discussion and putting this question to both Nav and Bibi. And the question is risk assessment for suicide finished? Nav.
So I think risk assessment as prediction is finished, or should be. Risk assessment as a tool or a score is finished, or should be. But assessment itself, how we assess people, is more important than ever. And the key things that have come out today are, assessments need to be individualized, they need to be personalized, they need to be empathic, and they need to lead on to management plans. So I think that's, for me, the essence of this.
Thank you. Bibi, is risk assessment for suicide finished?
Yes, I think I don't want my risk assessed. I want to be made safe. So I would say an assessment of how to keep someone safe is probably the way I would describe it. and that would necessarily include risk as a factor, but it wouldn't, I don't know, it just doesn't feel like the thing that I would want to focus on. I think safety is the thing that I would want to focus on.
Thank you very much. So there you have it. We've run out of time. Thank you so much for coming today. Thank you, Nav. Thank you, BB. And thank you to the University of Manchester for organising this webinar. If you want to read the paper and the comment, the link is right at the top of the chat, and you can find it on the Lancet Psychiatry website. I think that it's a great point to end on, to say, maybe it is the end of the road for risk assessment, but it's the beginning, hopefully, of a new era in helping people to keep safe. So thank you very much again to everyone for joining us, and this discussion will no doubt continue. But for now, thanks and goodbye.
Goodbye. Thank you.
Thank you.